Okay. Can you see the PowerPoint screen?
Yep.
Yes, I'd like to start. Thank you so much for having me in this group and giving me an opportunity for presenting Niedermeyer chapter for dementia. I'm Daegun Kim, affiliated so for long for the database project here in Korea since 2011, QEEG Tech in iMediSync Incorporated, which is creator of AI-based QEEG analysis platform with sex-classified database. Today, I'd like to introduce EEG findings for dementia, which is covered in Niedermeyer 6th and 7th edition, especially focused on Alzheimer's disease. In this presentation, I'd like to briefly introduce about Alzheimer's dementia and possibility of QEEG for the early detection and monitoring of progress of Alzheimer's dementia, and then summarize the QEEG findings for Alzheimer's disease in current research and Niedermeyer book. Finally, I'd like to introduce briefly KFDA registered AMCI QEEG biomarker. I'd like to start the first part, Alzheimer's dementia and possibility of QEEG. The World Health Organization has declared dementia to be one of the biggest health challenges in the future because non-degenerative disorders are the most prominent underlying condition in which no modifying treatment exists. Due to the increasing number of older people worldwide, the prevalence of dementia will increase from about 45 million people today to 130 million during the next 30 days. Now we have a new patient every 3 seconds. The estimated worldwide cost of dementia was $818 billion in US, will rise to $2 trillion by 2030, comparable to market value of companies such as Apple, Google, and recently Amazon. Alzheimer's disease is the most frequent cause of dementia, followed by vascular dementia, dementia with Lewy body, and other forms of neurodegenerative disorders. I'd like to mention here briefly about Alzheimer's disease and Alzheimer's dementia. Pathophysiology for the Alzheimer's disease is amyloid plaques and neurofibrillary tangles, simply plaques and tangles. The plaques are monitored by FDG PET, while tangles are measured by cerebrospinal fluid tapping. Alzheimer's disease is diagnosed by the pathophysiology, but Alzheimer's dementia is further diagnosed by difficulty in daily life. Alzheimer's disease is one major causes of Alzheimer's dementia. I'd like to differentiate Alzheimer's disease and Alzheimer's dementia. In this slide, the pathophysiology of Alzheimer's disease, plaques and tangles are depicted in details. As microscopic changes, amyloid beta plaques formed between neurons, tau protein aggregate into neurofibrillary tangle inside the neuron, eventually making neuronal death. After accumulation of microscopic changes, structural changes will be started, especially from the hippocampal area. This slide shows Alzheimer pathophysiology in more detail in terms of developing treatment. Here is the amyloid hypothesis. Amyloid hypothesis is the accepted mechanism to account the Alzheimer disease. Amyloid beta is produced and then forms oligomer, and then amyloid plaques, and so on, and tau aggregate into tangles, neurofibrillary tangles, and also pass through the synapses. This is the hallmark of the pathophysiology of Alzheimer's disease. People try to tackle the plaques and tangles through enzyme, immunotherapy, anti-inflammation, but so far no drug has been shown to reverse, stop, or slow the condition advance. A review by Cummings 2014 showed that more than 400 clinical trials conducted the last decade revealed a failure rate of 99.6%. According to 2019 paper of future direction for developing effective Alzheimer's disease therapies, none of AD modifying treatment has reached regulatory approval. This figure shows a slow march of the Alzheimer's dementia. Alzheimer's dementia develops slowly, and brain pathology can be found decades before clinical symptoms are seen in patients. The slow march starts from the amyloid plaque, and then tau-mediated neuronal injury, and then structural changes, in the end, starting memory impairment and functional deficit in daily life. The 10 to 15% of people with mild cognitive impairment go on to develop dementia each year. Prior to stage of dementia, two stages of impaired cognition are frequently defined: subjectively cognitive decline, the stage of subjectively experienced impaired cognition, which is not supported by neuropsychological testing, and mild cognitive impairment, which is supported by in-depth testing. In both stages, the individuals are able to perform activity of daily life, but they are at high risk of developing dementia. If when we find modifying treatment, such treatment should be initiated before the disease has progressed to a clinical state with severe cognitive decline and impaired function in activity of daily living. Therefore, it is of importance to find valid biomarkers that could identify people that have a high risk of developing dementia, preferably the underlying cause of dementia. This figure shows hypothesis of dynamic biomarker, including EEG. In the preclinical stage, amyloid beta start to accumulate, and followed by phosphorylated tau protein, and structural changes, cognitive deficit, and difficulty in daily life, as is seen in a previous figure. As you can see in the figure, EEG alpha decrease and EEG theta increase, accompanied by the earliest change of the preclinical stage. Then we can take advantage of EEG methodology, while the use of various MRI, PET method, and cerebrospinal fluid examination, measuring concentration of amyloid beta, phosphorylated, and total tau protein, as well as other protein, including inflammatory markers, have shown to be helpful in predicting patients with MCI and SCD who will convert to dementia, especially to AD. However, the use of PET and CSF biomarker are time-consuming and personal consuming and cost-consuming, and some of them are invasive and consequently non-ideal for use in daily clinical practice, except in subspecialized setting. Therefore, the biomarker are generally not used in primary care setting and not at all in countries with poor economy, and some will not be applied where doctors are reluctant to use invasive methods such as tapping cerebrospinal fluid. Electroencephalograph, on the other hand, is low-cost, non-invasive, simple examination, can be used in most clinics and even in primary care setting, especially if automatic reading method is applied. Furthermore, EEG changes is more substantial compared to structural changes, especially in preclinical stage, and user-friendly and affordable compared to amyloid PET imaging and CSF tau monitoring. In the last decade, studies were published which examined the power of EEG to detect those persons with MCI that will convert to dementia. As far as I know, the first pioneering 7-year longitudinal prediction research for subjective cognitive decline group, having only subject complaint but no evidence of cognitive deficit, was performed by Roy Zhang at New York University School of Medicine. In the research, decliner differed significantly from non-decliners, characterized by increased theta power, and slowing of mean frequency. This slide shows normal aging and cognitive decline at the same time. The thing is detect the decline trajectory as early as possible and start intervention for neuronal and cognitive reserve. A recent Cochrane review, however, does not support the use of amyloid PET as biomarker for AD. I think this means that pathophysiology itself could not directly account for the symptoms, but maximizing cognitive reserve through managing risk factors such as nutrition, exercise, and stress management can counterbalance the pathophysiology, and combined effect could be monitored through QEEG. That's one of the new wave in the Alzheimer prevention. I'd like to share this with this community. In the second part of the presentation, I'd like to summary QEEG finding in dementia chapter of Niedermeyer book 6th and 7th edition with some recent publication. According to the Niedermeyer 7th edition, chapter 16, EEG in dementing disorder, the editor for the chapter, Claudia Babiloni, introduced a 2009 review from Jelic. The review can be summarized as this slide. For the QEEG finding of the MCI group, the increased theta, decreased alpha 1 source at temporal parietal occipital area, decreased alpha and gamma coherence, and decreased global field synchronization were proposed as a MCI biomarker. For the dementia, increased theta and decreased alpha and beta in initial phase and end up being delta increase. Decreased mean frequency, reduced alpha blocking upon eye opening, diffuse slowing more pronounced in temporal and parietal area, and anteriorized alpha, decreased coherence in alpha and beta, decreased synchronization and complexity were proposed too. Recently, international working group argued that diagnostic biomarker for Alzheimer's dementia have to be measured pathophysiological hallmark of the disease directly or indirectly, so to speak, amyloid beta, total tau, phospho tau. Although studies examining the combination of cognitive tests with CSF protein, MRI, FDG PET have shown excellent results in identifying people with MCI that would convert to dementia, but rather than molecular, biomolecular, structural imaging, QEEG functional imaging could be more effective in practical sense and also in terms of integrative approach, both considering pathophysiology and resilience at the same time. According to the 2019 review in Frontier Journal, there were a lot of correlation studies for the pathophysiology of the disease, might be reflecting the guideline of the International Working Group. In the SCD, subjective cognitive decline phase, anteriorized alpha were detected in amyloid positive group. In the MCI phase, decreased functional connectivity with ApoE4, genetic risk factor for Alzheimer's disease. Along the MCI to AD phase, there was an increasing slow activity trend with tau, decreased alpha with tau, increased theta with tau, decreased alpha and beta functional connectivity with pathology, etc. Decreased functional connectivity at alpha and beta and gamma band and increased functional connectivity and at delta band were consistent findings, as we can see in many reviews. Here is a QEEG summary for the normal aging. We have to know normal aging and cognitive decline. In 7th edition, chapter 16, in EEG in dementing disorder, in the normal aging, posterior alpha reduction in senior were normal, but alpha frequency less than 7 to 8 Hertz or slowing of alpha peak frequency of 1 Hertz over 1 year could be expect pathology. Less efficient communication in senior were expected in terms of partial directed coherence, synchronization likelihood, decrement of path length in the graph theory. The theta and alpha coherence were decreased with aging, but beta coherence were increased in normal aging, whereas beta coherence usually decreased in cognitive decline trajectory. The slow focus of delta or theta in the anterior temporal area, especially in left hemisphere, could reflect memory issue. This is the normal aging and the pathological aging. I'd like to add some more normal aging and abnormal aging from the 6th edition. In the normal aging, spatial distribution become more uniform in elderly and beta decrease with aging, while elderly women have more beta than men. Focal abnormality, especially in left frontotemporal area, are highly prevalent. The white matter intensity in healthy elderly have also been associated with decreased EEG coherence and cognitive ability and intermittent temporal slowing. Temporal slow activity were associated with the impaired word fluency, ventricle widening. The temporal slow activity should considered pathologic when 9 criteria of BTTE, benign temporal transient of elderly, were not fulfilled. Sleep onset PIRDA, frontal intermittent rhythmic delta activity, and SRETA, subclinical rhythmic EEG discharge of adults, can be found in resting EEG recording for normal aging, especially in maybe in the during drowsiness or sleep onset. PIRDA or SRETA can be found in normal aging. I'd like to briefly introduce the EEG biomarker of AD from the 7th edition. Widespread decrease in the posterior power density in alpha and beta, while increase in theta and delta, and reduction in alpha peak frequency, low reactivity of alpha power density to eye opening were introduced at 7th edition. In terms of connectivity, decrease of alpha coherence, increase delta coherence, decrease alpha and beta grandeur causality from parietal to frontal area, decreased phase lag in the delta and theta within frontal and between frontal and temporal parietal area. This is the AD biomarker. I'd like to add EEG biomarker for AD from the 6th edition. The increase in theta and decrease in beta are the first sign, and then slowing alpha peak frequency could be followed. Finally, alpha decrease and then delta increase. Other researchers say that beta and alpha decrease and then slowing alpha peak frequency and further increase in theta and delta activity. The increase of theta may be outspoken in early onset AD compared to late onset AD. Temporal epileptiform mimic AD. EEG slowing correlate with ventricular widening, cortical atrophy, and worse psychometric performance. Decreased alpha correlate with hippocampal atrophy and poor MMSE score. Lower alpha band reactivity correlate with decreased performance. In terms of connectivity, EEG biomarker for AD, decrease in alpha and beta coherence and decrease in theta coherence interhemispherically, decrease in alpha coherence, specifically in left temporal area. Parietal to frontal information flow in alpha and beta band is disrupted. And nonlinear measure also showed reduced connectivity, while healthy subjects show high clustering and short path length, so-called in the small world topology, but AD shows random network. Loss of connectivity in AD also correlate with many measures like MMSE, atrophy of corpus callosum, or MMSE, or clinical dementia rating, and performance of psychiatric tests. Loss of connectivity correlate with these many measures. Most important thing is not the biomarker of AD and MCI itself, but the QEEG sign of progression, which could be found through longitudinal study, not by cross-sectional study. Who is progress from MCI to AD? Who is stable in MCI and not progress to AD? The picture for the progression from MCI to dementia were global alpha decrease, anterior localization of theta alpha and beta source, reduced posterior alpha rhythm, global delta theta alpha activity, and increased alpha 3 to alpha 2 ratio. I cannot understand these two, so I have to found the reference, but I did not review that. But this is not. It is difficult to understand, so I marked as red. In the longitudinal study for the decliner, the increased delta theta and decreased alpha beta power at parieto occipital area. I have to found this literature too, this reference too. I'm not sure it in red area. Increased theta and decreased beta power and mean frequency. Increased delta and alpha 1 in parietal and occipital source, reduced graph theory connectivity were found for the progression biomarker from MCI to dementia in 7th edition. I'd like to add from the 6th edition, the most consistent finding for the decliner compared to the non-decliner seem to be increase in the theta activity. As you can see in the Roizen study in the first part of the presentation, in particular anterior temporal area, in addition to increase theta power, slowing of alpha rhythm, alpha peak frequency, and decreased alpha power may be important progression biomarker from MCI to dementia. Studies during cognitive tasks or employing measure of functional connectivity show less consistent results, possibly due to unknown compensation effect. In the rest part of this presentation, I'd like to briefly introduce MCI QEEG biomarker as a KFDA registered medical software recently. This slide shows the sample result of iSync Brain M1 QEEG biomarker for early detection of Alzheimer's disease. The iSync Brain M1 is cloud-based AI algorithm using 19-channel resting state EEG data for early detection of prodromal stage of Alzheimer's dementia. When user upload raw EEG data as EDF format on iSync Brain, iSync brain engine remove the noise and extract various EEG features which would be put into the trained machine learning algorithm. Then probability score is calculated from 0 to 100. The scoring system consists of sequentially combined different machine learning algorithms. I will explain in next slide. Below 50% will probably be healthy normal population. From 50 to 60% will probably of subjective cognitive decline. Over 60% will probably the MCI. Above 85% will probably be AD dementia. iSync brain M1 can be used to detect AMCI from age-related benign memory decline when patients over 50 years old who complain subjective memory decline. Memory decline following a major cerebrovascular event or traumatic brain injury will be out of indication. More than 2-minute eye-closed resting state 19-channel data is used for the AMCI detection. This slide shows current iSync brain M1 model comprising 3-step machine learning algorithm, which are AD model, AMCI model, and amyloid model. AD model detect probable AD as 85 to 100%, and AMCI model detect AMCI. Among the AMCI, we can apply amyloid model to further detect progression probabilities. In case of AMCI, predicted as amyloid positive will show 70 to 85%, while predicted as amyloid negative will show 60 to 70%. In case of normal amyloid positive, prediction will show 50 to 60%, and amyloid negative prediction will show 0 to 50%. This is our 3-step machine learning model for detect early prevention of Alzheimer's disease. We applied this model and classify five different stages: normal, SCD, AMCI, low risk AMCI, high risk, and AD. Each machine learning model are using about 100 key biomarkers selected from 20,000 iSync brain QEEG features. This is a result of KFDA multicenter clinical study for the AMCI model. The AMCI detection accuracy was 91%, sensitivity was 93%, and specificity was 90%. After the AMCI model, AD model, amyloid model are further developed and integrated now. I'd like to wrap up this presentation. QEEG is effective tool for early detection of Alzheimer's dementia from the SCD phase, which might reflect not just pathophysiology, but also cognitive reserve. The QEEG functional neuroimaging will give a cost-effective prediction of Alzheimer's dementia compared to conventional biomolecular or structural imaging. As a monitoring tool, QEEG can easily be followed with any kind of early intervention such as medication, neuromodulation, nutrition, exercise, stress management, and etc. Automated QEEG analysis platform combined with three-step machine learning model for AD could provide a new wave in Alzheimer dementia prevention. Thank you so much for your attention.
Great job, Dae-kun.
Yeah.
Thank you so much. Must have been
Thank
a ton of work going
Yeah.
through and figuring all that stuff out.
I'd like to review dementia topic related to non-AD, non-Alzheimer dementia in Niedermeyer book in another time.
Oh, that'd be great.
In Niedermeyer book, half is the Alzheimer dementia, and another half is the another cause of dementia. There are many things in there, so I'd like to cover another time, sometime.
Sure.
Yeah.
Sounds good.
Question. I think Jay had a question. Are you muted, Jay?
All right, I'm in. Yeah, I had a question. Dae-kun, did you say that if the patient has a head injury history that this model won't work for them?
Right. All head injury and vascular event is excluded. All the clinical population recruited in our clinical study is dementia, Alzheimer dementia, and the amnestic cognitive impairment. The other causes of dementia is excluded in the clinical study. So vascular event and the traumatic brain injury cause of the dementia cannot be detected with this model. We have three models: the Alzheimer dementia model, and MCI model, and amyloid model. Amyloid model is the amyloid is one of risk factor for the Alzheimer dementia. So amyloid model is one of the model for detecting the Alzheimer dementia probability.
Question, Dae-kun, is I don't know if Jay had a follow-up question to that. So let's stay there for a second. No? Is it available now for us to look at files if we had clients that we thought might be in a clinical situation where it would warrant having an early dementia screening? Is this available for us to use?
It is available for use as a clinical purpose here in Korea, but outside Korea, you can use it the research purposes, not the clinical purpose. Just reference or just evidence, not for the diagnosis or not for the medical use. The medical use is now only cleared just here in Korea. Outside Korea, you cannot use it as a medical purposes, but you can use it just your reference or research purposes or monitoring some Alzheimer patient, training or neuromodulation or brain brightening, neurofeedback. You can use it.
Would it be an option for you to show us somebody in the database so we can look at a queue that has it? Is that something that anybody else would be interested in?
I'd be interested in that.
Yeah, I'd be interested in that.
Yeah, sounds like there's a whole lot of thumbs up I saw going on. So sweet.
because I mean, if you already have them in the database, you know, we could do a screen share and you could pull up some stuff and kind of, it'd be fun to point it out and see the different differences. I don't know if maybe that's too much work or it has a whole nother presentation, but idea.
I don't know. Is that something you'd want to do now, Deku? Or would that be a separate, just set up a time? I mean, most of the folks here are in the grand rounds as well, so that might be, you know, since that has more of a clinical focus, that might be a good place to do that, but we could certainly do it here as well.
If you have data, we can test together in some time for testing our AMCI biomarker model on iSync brain. If you have some disease AD or Alzheimer amnestic MCI or SCD, if you have some data, we can set up a time to test together.
Yeah, I mean, I don't have any exact ones for that specific reason, just wanting to become more familiar with seeing it. But maybe somebody else does.
I have tons of data, but almost all mine have head injuries. So, I mean, I have a case that I feel like is progressing to Alzheimer's and started with a head injury though. So it seems like they're disqualified from using it.
Would they be disqualified, or would it just question whether we could rely on the output? I mean, I would think we could still run it and see what it says. They could.
Could you please repeat? I didn't understand you. Okay.
Jay, can you restate the question, please?
You know, I have a patient who had a major head injury a couple of years ago, and it really feels like he's moving into dementia, you know, severe memory impairment, really not able to function in daily living. But since, you know, all the head injury folks are excluded from this discriminant, I don't know if that's the right word for this classifier. What would there be something to be gained from running the data through this anyway? Could we learn something from running that kind of data through the MCI model?
I'm not sure the head injury people with dementia symptom can detect our detection biomarker. I'm not sure our biomarker can detect head injury initiated dementia. I'm not sure, but we can try.
Or we could try it.
Yeah.
I'd like to see the data.
I can't stay to past 11, so I can't do it now, but if we wanted to do it another time.
I'd like to suggest that there might be another form of sort of Alzheimer's that I've been lecturing on for about 5 or 6 years now, and I've been co-lecturing with Becky on it with her football players with concussions. I think the last 3 or so years, you and I have been lecturing on that. And we're calling it a thalamocortical disconnect. And we see it a lot in concussions, but I've also seen it in people with post-viral infection. And I'm doing DC recordings with the EEG, and it seems to be there are extreme DC shifts where these people, like they're in the millivolt range, and it shuts down the thalamocortical loops so they cannot make alpha. So they're very low voltage, almost flatlined in the affected area. Sometimes the entire head is flatlined, and sometimes just certain sections are. A couple other things. When you're flatlining basically and you cannot make alpha, I think in general, we're probably seeing something on the order of potentially 100 billion synaptic impulses that are lost per second. And another thing that we see is, in addition to having really no alpha to speak of, but these people also have generalized anxiety. They have severe insomnia, really, really severe insomnia, which Becky and I have observed, and it's excruciating insomnia because they cannot make delta waves either, or not, at least not proper delta waves with sleep spindles and all. And we've got a big lecture that we wouldn't mind presenting maybe on it at some point in time, and showing all this stuff. What else can I say about it? It looks like they're low in lactate, they're low in ATP, which in turn shuts down norepinephrine, which in turn seems to disrupt the calcium gradient, and without calcium, you cannot get synaptic transmission. And so the lecture gets into all that kind of stuff. But I think this is a third type of Alzheimer's, perhaps, that is kind of being off the radar at the moment. And Jay, I know you've taken in that lecture a couple of times now, and I really just seem to apply well to say these people who are, again, concussed or severe viral infection. They're very low voltage, essentially no alpha. So I set up my room, my brain lab, to be in a very alpha conducive state. They're reclined in a chair, there's white noise running, there's a blanket, they're warm, they're snuggly, everything, they got a footstool. You couldn't be in a more alpha conducive state, and these people still cannot generate often the slightest amount of alpha. And we believe that morphs into chronic traumatic encephalopathy. But if the doctor doesn't know you've had a concussion, they call it Alzheimer's. But we do believe this type is one and the same. And maybe John can comment on that too, because John, you've seen us present on that as well, and I think you've come across that also.
I've seen it, but at this point in time for me to comment, it would be more anecdotal. I've seen it. I've seen it in a clinical setting, but I would love to run numbers to see how it all shakes out.
Yeah, I'm really trying to get an Alzheimer's study rolling. One of the things is that entrainment dries up lactate 260% in 5 minutes. And we think that's a key because I can entrain people, and usually typically in randomized SMR beta. And this is a spin-off of what Budzinski and Leslie Sherlin were doing. When we randomize it and just pound them with all this, what I would say randomized or dirty stimulation almost, usually in about 15 or 20 minutes, you'll suddenly see massive alpha waves start to emerge, even though we don't entrain in alpha. I typically use SMR beta or randomize, and it's randomized, which helps. And sometimes I use alpha beta as well if they have depression, but it's also randomized. And then way back, 20 years ago, Leslie Sherlin and Tom Budzinski were doing a cognitive decline in a senior's home. They're doing a study using entrainment. And this one lady who got into the study was only 57. She was shuffling around the senior's home and with severely progressing Alzheimer's. And they got her, she kind of by accident got into the study, and she had no alpha waves. And that's one of the things they observed in the EEG. She makes no alpha. And in the course of 3 months, she recovered from severe dementia to completely normal function and moved back into her own home, could once again walk through downtown Seattle and had a completely normal life after. So, and Becky has observed similar things with football players whose lives were just a train wreck, and some of them made complete recoveries. You want to comment on that, Becky?
Can you hear me? I think my mic is not working.
We can hear you now, Becky.
We got you.
Oh, cool.
It's really quiet.
Okay, cool. So, where do I start? In a nutshell, I would get these guys in, and I couldn't even get a decent EEG because they had so much anxiety. Sometimes the cap would get wet, even though my room was chilled down like a meat locker at about 65 degrees. They would have so much anxiety. The cap would literally get soaking wet. I could take it off and put it on a cloth covered chair and there'd be a wet mark. That was common, and so much muscle tension that you couldn't get a decent recording. And so I would just put them in those instances, I would just use the AVE, and this big commercial for Dave, but I would use the AVE just as triage, because that was all I could get. And it's not like I could have them come back the next day. It's like, oh, this isn't working, come back tomorrow, we'll try it again. That would just make them mad. I wanted to give them some relief because I'm an empath and I don't like to see people suffer. So I would just leave the cap on them, albeit wet if it was. I would just leave it on them. And I would leave the recording running, give them the AVE, and not on alpha, not on Schumann. I would put it on a brain booster or the light bulb, some sort of a beta setting. Usually the brain booster, if you have an AVE or a David Delight, it would be brain booster. Yeah, so Dave could comment on this, either brain booster number 3 or 4. Typically I would use number 3 every time. And they would typically fall asleep within 5 minutes. And I would just let the thing record and then gently wake them up, and depending on how much time I had in my schedule or where they needed to be. Sometimes I'd let them sleep for an hour just because, and then they'd wake up. I didn't like to wake them up because you didn't know what you were going to get. These big 300-pound guys, they might get mad, and they were already there because they were explosive, and it could be scary, especially when you weigh about a third of the, you're about a third their size. You don't want to bother them. So, but I would let the thing run, and then Dave and I would meet online afterwards, and we would look at these recordings, and just like you said, you would see alpha start to happen. I'd let them wake up and watch their EEG, and there'd be alpha. We have recordings, we have snippets, it's all in our presentation. And no kidding, the muscle tension would diminish. You'd start seeing some alpha. I mean, it wasn't perfect, not like they were cured in one session, but at least I could bring them in the next day almost every time and get a decent recording. And they got a decent nap, and they would tell me, Miss Beck, that was better than any weed I ever smoked. No kidding. So because they were making alpha. Anyway, that's my 2 cents.
It's another little, I don't want to be too self-promoting, but on the physiology side, one of the things is that oligodendrocytes must see action potentials, or they don't know where to myelinate. And see, I'm guesstimating that in some cases, we're probably seeing up to 100 billion action potentials per second that are lost because they've lost the thalamal cortical loop. And one of the things in that we see, basically, a well-myelinated nerve can ping a signal across the corpus callosum in about 30 milliseconds, which equates pretty close to 30 hertz. And this is where we see most of the severe phase anomalies are in the 24 to 30 hertz band. You see a lot of slowing in there. And I think it has a lot to do with the fact that astrocytes, oligodendrocytes are probably not myelinating like they should. And so we're seeing slowing in the networks. So I always look at phase in this population. Phase really is severe. And entrainment, for whatever reasons, probably because there's a large lactate and ATP connection with it, you see dramatic phase normalization, sometimes as quick as 20 to 30 minutes. But anyway, I didn't mean to sort of hijack the conversation, but I thought it's another.
I'm curious, Dave Kuhn, I know that iSync is developing dry headsets with photobiomodulation. Is that correct? And I'm wondering if there's any trial or look at how to use this technology around dementia or Alzheimer's.
Yeah, that's confidential information in this group. Yeah. Okay. Yeah, we developed the dry headset and simultaneously modulating photics and the microcurrent. That's we are developing now. At this stage, we can measure the 19-channel EEG with dry sensor quite nicely and already integrate the right therapy as a home device for the many people who cannot go to the hospital. They can measure the EEG at home, and the QEEG analysis guided neuromodulation can be done with the supervision of the expert at home. That's our device and software platform combination for the untech era nowadays, and many people who cannot go to the hospital. For example, Parkinson patients cannot go to the hospitals easily, so they can use it. And Alzheimer dementia, they can use it. And many developmental disorder people can neurofeedback in their home. That's our next device platform is under developing now, and we'll release next April, I guess. Basic dry sensing and PPG sensing is now established, so we can try to integrate neuromodulation on the same headset now, and combining with our analysis platform, we can give person the QEEG guided neuromodulation at home. That's we are thinking now and developing now.
Exciting stuff.
I have a question, Dae-kun, about the machine learning model you guys are using. Did you say you are inputting 20,000 features for each patient?
Yeah.
And
basically, I think a brain makes the 20,000 QEEG features, and each model we training the disease group and the health control group to maximize the separation efficiency. We finally detect some important feature around 100 to make a model.
And I don't know if you're able to say this, but what kind of machine learning model are you guys using for the AD detection?
There are many kind of model we use. The three machine learning model use the different machine learning approach. So it is another kind of confidential at this moment. So I will let you know in some time.
Okay. I promise I won't try to make it myself.
I have a question, Dave.
Yes.
It's Mary Tracy here. I'm noticing that a lot of the changes that are seen in the brain as a result of Alzheimer's include a slowing of alpha frequency and a persistence of alpha and theta in the eyes open condition. So my question to you is one about vigilance modeling, and if and how you distinguish and discriminate and differentiate between vigilance changes that are a consequence of Alzheimer's and the pathophysiology of Alzheimer's that may be causing these changes that are very similar to vigilance changes. And I'll take my question off.
Maybe this is question for me, right? There are two Dave, so I have
think it's
to.
for you, Dave.
I prefer Dagon in this meeting.
No, the other Dave already said enough. So I'm going to talk with you now. Sorry, Dave.
It's very good question. In this model, we train the resting state awakening period of data for making a model. So the drowsiness is rejected from the data. So the vigilance is controlled in terms of the data preparation period. It is not at automatic at the iSync brain automatic denoising. In the automatic denoising, we did not apply the vigilance modeling yet, but we can now developing vigilance model based epoch rejection. We are now under developing, but at the stage of the modeling of AMCI biomarker, we manually denoise or manually select the clean portion and awakening period of the data for all the subjects. So that's my answer. The vigilance is very important to control for the preparation data for the clinical study.
And I noticed the way that you control the vigilance modeling in one of my patients, Joe and I went over the other day. He's helping me to get introduced to the use of your product. And I noticed that all of the low vigilance material had been automatically excluded. Can you hear me? I'm having an interruption in my computer transmission. Can you hear me, Dave? Dae-kun?
Yes.
Okay. So what I'm wondering, and I don't know if you answered this because I'm having some interruptions in the computer transmission, but would it be possible to investigate vigilance modeling as a way of detecting early Alzheimer's? Is that a stupid question?
No.
Do you understand what I'm saying, Dae-kun? That I understand that that your artificial intelligence algorithm removes the low vigilance activity so that we're seeing what appears to be only wakefulness in an eyes open recording, for example. Is that correct?
Sometimes at this moment, the vigilance modeling based rejection is not applied in our AI denoising process. So, but sometimes the AI detect is not perfect. So we offer the manual denoising. If you do not satisfy the AI detection, you can do the manual denoising to include that component or reject that component if you want. So you can make your own clean data using our process.
Okay, I think I'll have to have a session with you personally because there was so much of the low vigilance that was automatically excluded from the file Joe and I were working on, and I made the incorrect assumption that your machine learning program scrubbed all of the low vigilance material in the eyes open recording. So thank you.
That would be, I mean, Dae-kun, if you were going to give a lecture on how the Amica denoising addresses low vigilance states, I would be interested in hearing that. I mean, we use your software all the time, and understanding more clearly the parameters of how it's going to scrub data, whether it's clicked as eyes open or clicked as eyes closed, and what's going to be included or excluded for those of us who use this clinically, that'd be really helpful.
So Dae-kun, correct me if I'm wrong, it was my understanding that the iSync Brain AI software select there are components. There will be 19 components visible, and it informs you which components it took out, and then applies the algorithm to the entire EDF that is submitted. Is that correct?
I do not understand, please. I'm
Okay,
sorry about it.
when we submit an EDF for the AI, it's going to apply that algorithm to the entire recording submitted. Is that correct? That was my understanding. The entire recording. It doesn't take out epochs, for instance, transient, something. It'll take out the components and you can see which ones are taken out, but it's going to apply it to the entire recording. If in regard to, is that correct?
In the before the component, before the Amica process, we reject the transient noise epoch, and then remaining epoch, using remaining epoch, we apply the Amica process to make a 19 independent component.
But so to address the vigilance issues, if I have somebody who's really tired and they're falling asleep, I may just go into some other software and just crop out, like you said, Mary Tracy. I would typically just select the most wakeful data because that's what I want to do my QEEG based on, is not a compilation of the sleepy stuff when I have people who literally fall asleep, and have it do a QEEG based on the whole conglomeration of the wakeful and the sleepy data. I like to analyze those things separately. So I'll maybe submit a piece of the most wakeful stuff and then write on my report and take screenshots of the sleepy stuff, and then also mention that the most wakeful data were selected for the QEEG analysis, but include screenshots of the K complexes and such, and the alpha dropout and sputter, and comment on it. That's just how I do it, my 2 cents.
So I do the same thing that you do, Becky, but before I do that, I take a look at the entire record, because those vigilance changes are diagnostic as far as I'm concerned, from a neurological perspective and a psychological perspective. And I think we can all agree on that, if someone is, in the lower stages of vigilance for most of an eyes open recording, we're going to think about asking them to get a sleep study at the very least. And there may be other factors that are impacting them, post-traumatic factors, TBI factors, things like that. But I agree that I would like to see the state of the individual's brain in its most wakeful state. I would like to see the components that exist. But again, I was uncertain in this record that Joe and I were working on the other day, which seemed to scrub a lot of the low vigilance stuff, if that was something that iSync just does, or if it was this individual recording. And I'm sorry, I'm beating a dead horse here, and maybe we should move on.
I think that's important.
I'm splitting hairs is good exercise. I'm curious, Dae-Kun, if with the dementia screening, there's an account for phenotypes. I mean, there's 11 genetically linked. I don't know that they're all genetically linked, but I believe many of them are at this point. There's Arns's circadian rhythm phenotype, which would be a 12th. And I'm curious if you have any thoughts on if the model that you've arrived at with iSync for dementia screening would be valid across all the phenotypes, or would there be some that should be excluded?
Basically, Alzheimer dementia is related to the two phenotype of the 11, among the 11, diffuse slow activity, and with diffuse slow activity with, and another is the eye open persistent alpha activity. These two phenotype is basically related to the Alzheimer dementia, I think. I'm not sure the circadian related thing. I don't know exactly what it is.
I mean, it's not well-known research, but it's available on Martijn Arns' the NeuroCare website for free. But he did propose a 12th phenotype.
I have to check that after this meeting.
I was going to mention for myself for Eyes Open, because EEGs are so dynamic and contextual in a sense, I always get sleep data for the last 2 weeks, because if they've had poor sleep, then I'm going to expect to see them have large bursts of theta throughout their Eyes Open recording because they're tired. And that's an important thing to note. If a person is really tired and then make big bursts of theta, but they can also then recover that and suppress that theta, it shows they've got good vigilance, in my opinion, because these are very sleepy, exhausted people, and yet they're still managing overall to maintain their attention over a 5-minute recording. I run on my Eyes Open typically 5 minutes. And I would consider that to be actually sort of a testament to them having good vigilance. If they can still pretty much maintain it, even though they do have theta bursts throughout, especially, let's say, if they're very tired. If they had a good night's sleep and they say, I sleep like a rock every night and they're pounding out big piles of theta, that's an entirely different story than someone who's sleep deprived.
Well, any other questions?
Sure. I have a quick question for Dae-Kun. Dae-Kun, I'm wondering if you're familiar with Dale Bredesen, who's probably the father of research in the field on Alzheimer's. And he's identified like 5 subtypes or 5 root causes, you know, like one's microbial, one's the ApoE4 genetic marker, and inflammation, you know, there's all these subtypes. I wonder if there was a correlation in the markers you identify with those subtypes. That would be really cool work if you could make a correlation there.
We don't have the correlation data with the ApoE genetic data, but we have some correlation with our biomarker, with the psychological testing, many kinds of psychological testing, and the PET and the tau measurement, but we don't have genetic correlation study data. But we have to research on the topic.
Cool, thank you. Are you familiar with Dale Bredesen's work?
I'm not familiar with please send a message for his name. I'm not familiar with his name.
Yeah, that would be a great person to look into or to partner up with.
Yeah, thank you for your information. Please send the name for me.
Yeah, we'll do. Thank you.
Thank you so much for your suggestion.
Hey, Dae-Kun, can you give Cody back the screen so the presentation will come down?
Yeah. Thank
Great.
you so much.
Thank you, Dae-Kun.
Yeah, I mean, that's sort of, thank you so much for that. That was a fantastic presentation.